right, welcome everybody to the final EMPH seminar for 2020. As always, please post any questions you may have in the chat box on YouTube, or you can post questions on the Google Doc that's linked to it. Today, we warmly welcome Jonathan Wells, who is a professor of anthropology and pediatric nutrition at the UCL Institute of Child Health. Jonathan's research focuses on pediatric body composition and energy metabolism. He uses evolutionary theory to address the association between developmental plasticity and health. He has pioneered and developed methods for measuring energy expenditure, body composition, and breast milk intake. So his work is truly global, with ongoing collaborations on almost every continent. And on top of all that, he supports clinical work at Great Ormond Street Children's Hospital and even finds time to write books. With that, I hand over to you, Jonathan.
Okay. Thank you very much for that kind introduction. I'm going to give a presentation on linear growth and life history trade-offs, an evolutionary perspective on strategies to address malnutrition. And this very much connects what I'm interested in. On the one hand, I'm involved in work that's trying to improve human health, but we're always interested in whether we can gain from an evolutionary perspective when trying to do this. Now I'm unable to advance my slides. So, here we go. So we know from many examples that linear growth is associated with health and benefits for human capital. We know that linear growth is associated with better survival in early life, with lower non-communicable disease risk in adult life, with improved,
Sorry, you're not sharing your screen anymore. Were we supposed to be seeing the slides?
I have a problem because I can't advance my slides on screen. So,
okay. Was it full screen when you did it? Because it
yes,
looked the same as before.
So do you want me to do this just...
Give it another try.
So if I do it like this, which is not full screen, is that visible?
You're not sharing your screen yet.
Okay. Sorry, what happened is when I shared the screen, I couldn't advance the slides.
Right, okay.
No, I can't control the keyboard.
Oh. Try now?
No.
Okay, that's
remote control, it says. Give mouse keyboard control. No, it should be in my control. So I'm not sure what the issue is.
Okay, an alternative is maybe if you send me the slides, I can show them from this end.
Okay, let me email them.
Sorry, everybody, for the delay. You are sharing your screen, though, with your emails.
That's unavoidable. I can stop that. Okay, so I have sent them. Some carrier pigeon is flying from Cambridge to Oxford.
Feels like it really is a carrier pigeon.
So I'm sorry about this. I think we've all got used to the fact that because the technology works 95% of the time, we still get caught out by the 5% that it doesn't.
Quite.
Most likely the carrier pigeon is obliged to go via London.
Yes, indeed.
That's the UCL server.
Oh. This is tedious, but I will
just check it's gone. Yes, that's gone. So sorry, it does just take a time for it to get through.
Mm.
I mean, I can probably keep talking. I can show the slides myself and just prompt myself.
Yes, do that. This has come through now, the PDF. So right, so if I now right, I'm going to share my screen, and what I need you to do is tell me next or something when you want me to skip. I'm going to mute myself now.
Okay. But I can't see yet the slides on your screen. Oh, perfect. Okay. So next slide, please. Okay, so I'm sorry for the short delay, but here we go. So we know that linear growth has many benefits for health and human capital. Better growth is associated with better survival in early life, with reduced non-communicable disease risk in adult life, improved physical capacity. It's associated with social status, has educational and economic benefits, and also transmits some of those benefits to the next generation with improved survival of offspring. Now, we also know that the greatest rates of linear growth are also associated with cancer, but I think we can park that issue because there are other ways to reduce cancer risk. So broadly, we can consider linear growth a very good thing. Next slide, please. However, what we can also see very easily is that many different environmental stresses act negatively on linear growth. And that's why Jim Tanner called it a very strong marker of human health and also society. So poor diet, food insecurity, infections, poverty, air pollution, gender inequality, psychosocial stress, all of them have negative impacts on children's growth. Next slide. We know that growth has a strong genetic contribution, certainly to adult height, but a slide like this also reminds us that there's a very important contribution of environmental variability. These are data from the Indian National Family Survey in 2015, and you can see a strong association between the Household Wealth Index and average height Z-score. So what I'm interested in this presentation are what are the consequences of this variability in growth, and also why do those consequences actually emerge? Next slide. So I'm going to take an evolutionary perspective. Now, very often when people talk about human evolution, what they're interested in are the traits that characterize all humans in general, such as bipedal locomotion and a large brain and high levels of sociality. Next slide, please. Next slide. And when we think of these traits, we generally assume that they must have evolved as some kind of solution to ecological stresses. And a lot of attention has been paid to the fact that during the last 4 or 5 million years, during which human evolution took place, the globe got cooler. That was associated with the spread of the savanna ecosystem in Africa. And we know that human evolution occurred in that context. So maybe these traits, such as large brain size, were solutions to the stresses of living on the savanna. Next slide, please. So that would give us the classical concept of adaptation, that a population has genetic variability, that variability is exposed to ecological stresses, and the result is a fitter genotype underpinning those traits that are emerging over time. Next slide, please. But the challenge for using that to really understand human variability today is that we know that in the last 150,000 years, humans have migrated all around the planet, and yet the level of genetic variability that has emerged has remained relatively small. The diagram on the right shows the magnitude of genetic variability within a species by the size of the tree. And you can see that the red tree for humans is more or less the same size as the yellow tree for eastern and central chimpanzees. So although chimpanzees occupy a relatively small range of habitats, they have the same level of genetic variability as humans do in their much larger degree of habitats. So clearly, we've not made extensive use of genetic adaptation in adapting to different environments. Next slide, please. So what else has gone on in human evolution that might explain this? Well, this goes back to the plot of a marker of global temperature. And you can see that alongside the general trend to cooling over the last 5 million years, what has also happened is that the oscillations of temperature have become more and more marked. And those temperature changes are likely to have translated into ecological change in the environments that humans occupied that were sufficiently large that within individual human lifespans, the environment would have changed. Next slide, please. That means that humans essentially evolved in volatile environments. And in volatile environments, the adaptive solution is not to develop a specific trait, it's more to develop traits that enable the management of ecological risk, and the brain is a good example. So humans needed to evolve the capacity for different aspects of plasticity, and that would allow them to buffer ecological stresses through different forms of biological flexibility. Next slide. Now, to understand how organisms adapt, we make use of life history theory. I'm sure many of you are familiar with this. We can consider that organisms are posed a series of questions: how fast to live their lives, when to stop growing, when to start reproducing, how many offspring to produce, and how much investment to make in each offspring. Next slide, please. And life history theory was originally developed to explain differences between species. So as you can see here, we can think of species being distributed across a continuum of relatively fast to slow life histories. And we can ask, why does a mouse typically only live for up to a year in the wild, whereas an elephant will typically live for 60 years? And the answer would lie in some or other form of genetic adaptation. Next slide, please. Now, the theoretical insight from life history theory is that those genetic adaptations arise through the differential allocation of energy. Traditionally, life history theory assumes that all organisms have to allocate energy between 3 different basic functions: maintenance, reproduction, and growth. And the idea is that if you allocate more energy to one of those functions, there's less energy available for others. And so there's always going to be trade-offs between those functions. Next slide, please. However, the more that I've worked on life history theory, the more that I have found that it's easiest or maybe more informative to consider defense as a separate function from maintenance. We know that defense can be considered from 2 perspectives. There's immune function against pathogens, and then there's the stress response against other types of threat. And we now have plenty of evidence that defense, immune function, and the stress response are directly challenging to homeostasis. They cause metabolic damage. They also challenge growth, and they also curtail reproductive function. So in a recent paper with Jay Stock in Frontiers in Endocrinology, we tried to set out in more detail the notion that defense should be considered a separate life history function. Next slide, please. So we use a 4-function model of life history, and we consider that organisms allocate energy between maintenance, growth, reproduction, and defense. Next slide, please. Now, how does an organism actually solve this allocation problem? Well, let's just take one ecological stress, extrinsic mortality risk, and one life history investment, which is maintenance. So let's take an animal like a mouse. How much should the mouse invest resources in maintenance? Next slide, please. Well, the mouse has many predators, so a high extrinsic mortality risk. It's not worthwhile the mouse investing substantially in maintenance because it's very unlikely to live long enough to reap the rewards. And so the mouse will invest a low level in maintenance. And that means that even if it's not predated, it will not have a long lifespan anyway. Next slide, please. But if extrinsic mortality risk were to decline, then the benefits of investing in maintenance would be greater. And therefore, if the mouse was not eaten by a predator, its lifespan would increase. Next slide, please. And so you can see how increasing investment in maintenance will generate a longer lifespan. Next slide. Now, we can apply the same logic of life history theory to looking at trade-offs within the life course, and this will give us a new perspective on growth. So once again, we can consider allocating more energy to one function, for example, fighting infections, and consider what that means for allocating energy to other functions, such as growth. Next slide. So that gives us an alternative concept of adaptation based on phenotypic plasticity. Plastic mechanisms are exposed to ecological stresses, and through reaction norms, the consequence is a more adapted phenotype. Although, of course, that adaptation is in the immediate sense, and it doesn't mean that the organism will be adapted to future stresses that it may encounter. Next slide, please. So we can use this approach to look at growth trade-offs that emerge during the lifespan. So I'd just like to start with one example of this. This was a study carried out by Emma Pomeroy and colleagues in Peru, and she looked at children aged up to 10 years of age. And she essentially looked at competition in growth between different components of the skeleton. And she did this by comparing children living at altitude and who are subject to many different ecological stresses, and compared them to children living in a lowland environment in more favorable conditions. Next slide. So this slide plots the deficits in the size of the skeletal components of the highlands children relative to the lowland children. Now you can see that in every dimension, the highland children were smaller, but there was also variability in the magnitude of that reduction. The trait that was least affected was the head and the trunk, just below 0.75 SD scores. Whereas the tibia length, the lower leg, was affected by more than 1.25 Z scores. So you can see from this that the impact on the lower leg is roughly twice the magnitude in Z score terms compared to the head and the trunk component to growth. So you can really see here a competition for nutrients, and some skeletal components have won and others have lost. Next slide, please. Well, that's very analogous to the thrifty phenotype hypothesis of David Barker and Nick Hales, when they suggested that if an organism is exposed to malnutrition in early life, it is likely to protect the brain at the expense of other organs such as the pancreas and the liver. So we can consider leg length as another trait that might be sacrificed in order to protect energy supply to the brain. Next slide. So that means that in more detail, we can think about different aspects of growth and body composition, not only as anthropometric traits in their own right, but also as markers of investment in different life history functions. Next slide, please. So, for example, we can take height and leg length in particular as proxies for early life investment in the function of homeostasis, because we know that leg length and height are both associated with better health outcomes. And we can take fat as a marker of investment in defense and reproduction. Now, we know that particularly in females, gluteofemoral fat is very important for funding lactation. And we know that central body fat is very closely associated with immune function, and it's also associated with the stress response. So central body fat can be considered a physical marker of investing more energy in immune function and the stress response. Next slide, please. Okay, so let's step back and take a longer term view of life history trade-offs. So to do this, we recently got interested in the origins of agriculture. Obviously, the most important thing, or perhaps the most obvious thing about the origins of agriculture, was that humans changed their supply of food. They shifted from foraging to either growing specific crops or having stock animals, and this changed the supply of food, but it also changed many other parameters of human life as well. Next slide, please. So one thing that also changed during the origins of agriculture was the level of exposure to pathogens and infections. By living in more dense sedentary communities, humans expose themselves to diseases that transmit easily within small populations, and we have no better example of that now than the COVID pandemic. Humans also expose themselves to diseases that might have jumped from their newly domesticated animals into humans. So overall, we know that there was a significant increase in the burden of pathogens. Next slide, please. So we can add these different stresses together. On the one hand, humans changed their subsistence practices. They started harvesting grain, processing foods, and dairying. That meant that they had increased energy intake, but also, on occasion, an increased risk of famine and food insecurity. They started living in sedentary communities. That helped promote shorter birth intervals, but it also increased the burden of pathogens. And together with J. Stock, I suggested that this might have generated systematic shifts in human life history trade-offs, generally less investment in maintenance and growth, and more investment of energy in reproduction and defense. Next slide. And here's one example of some supporting evidence, again led by Emma Pomeroy from Archaeology in Cambridge. She examined the skeletal archaeological record in India. And as you can see here, since the Mesolithic foraging period, height in Indian populations showed a significant decline. And this is supported by many other studies of human populations worldwide, that generally agriculture was associated with declines in height at the same time that there were increases in fertility, and there were signs of increase in markers of ill health. So our life history perspective may help connect these things, that height went down as fertility went up, and there was more need to allocate energy to defense and immune function. Next slide, please. Okay, let's switch back attention to what happens within the life course. We don't know whether those agricultural trade-offs were driven by genetic change or simply by plastic responses. But here we're looking at patterns of growth faltering, so undoubtedly mainly plastic responses, in 54 low and middle income country populations in early life. And you can see that overall in these 54 populations, linear growth faltered markedly between birth and 2 years of age. And the change was over 1.5 Z-scores. And then after 2 years of age, growth appeared to be relatively stable. Next slide. Now, you might think that it's difficult to assume that linear growth faltering is a good marker of undernutrition. And indeed, some people have challenged the idea that stunting is actually a response to undernutrition. But I think we're gaining from longitudinal studies new insight into exactly what the association is between undernutrition and linear growth retardation. We're gaining the insight that stunting is a response to prior thinness. So the body resolves its thinness by reducing the rate of linear growth, and that allows more energy to be directed to tissue composition or accretion. Now, over time, if a child suffers repeated episodes of wasting or thinness, that will lead to a cumulative stunting of growth over time, which is exactly what we see in the first 2 years of life. And that helps understand the question of why are stunted children, who might appear only to be short, at increased risk of mortality. Those currently short children were previously thin children. They were more undernourished than you might see now when they're only short. And that wasting earlier on may have had much longer term and more severe effects on their phenotype and their survival chances. Next slide, please. So we can start to think of these life history trade-offs and to see, for example, that infections or a reduced energy supply is clearly likely to have an impact on growth. So you could say this is a classic trade-off: more allocation of energy to defense, less energy available for growth. Next slide, please. However, growth may not be the only life history function that is affected by allocating more energy to defense. This slide shows the follow-up data of children in lowland Nepal where what's on the graph is the deficit of children who were stunted at 2 years relative to those who were not stunted at 2 years. And what we're doing is looking at 8 years to see what the longer term consequences are. And once again, you can see that every trait is reduced in the stunted children. So they're smaller in every dimension. But once again, you can see a great deal of variability across the differential traits. Interestingly, fat mass is the most affected. So the most obvious thing about these children at 8 years, if they were stunted at 2 years, is they're still thin. They have not got high levels of body fat. You can see reductions in girths, in skin folds, and in leg length. Interestingly, the study had data on the dimensions of the kidney, and you can see that the kidneys are about 4% smaller as well. Now, if we adjust for the shorter height of the stunted children at 8 years, even after doing that adjustment, they still have smaller kidneys. So the reduction in kidney size is out of proportion to their shorter height that's evident at 8 years following their earlier stunting. So stunting has had a bigger impact on the kidneys than you would recognize if you just looked at the height of these children. Next slide, please. So we can look back at our trade-off plot, and we can see that actually it's not only growth that is affected in the long term. Allocating more energy to defense reduces energy allocation to growth, but also traits that are associated with long-term maintenance. And this is starting to help us understand why poor growth in early life has more significance for a range of health outcomes. It's not just about being small, it's about developing traits that will become less healthy. Next slide, please. But let's go back to our plot of early growth filtering in these 54 countries. If we look closely at the very early period of filtering, we can actually see that at birth, the average Z-score deficit was already around 0.4 Z-scores. So that tells us that these children had already started growth filtering in utero. Next slide, please. Now that shifts attention from the external environment to maternal phenotype. Now there are many different aspects of maternal phenotype that are important for nutrition in utero. Some of those relate to relatively stable aspects of maternal phenotype, and these include maternal height and uterine volume and energy stores, which are particularly important for funding lactation. But then there are also markers of maternal metabolism because they influence the passage of nutrients across the placenta to the fetus. So here we might be looking at factors such as blood pressure, glycemic control, and lipid levels. So what we can see here is that the earliest aspects of phenotypic plasticity during the first 1,000 days, under the windows of pregnancy and lactation, any adaptation of the phenotype of the offspring is actually in response to maternal phenotype, not to the external environment directly. Next slide, please. So that allows me to introduce what I've called the maternal capital hypothesis. This is based on the embodied capital hypothesis of Kaplan and colleagues, where they have considered the body as a stock of different types of investment, cognitive investment in the brain and somatic investment in the body. Now, for maternal capital, we can think of all sorts of different aspects of capital that may help the mother invest in her offspring. She may have cognitive capital, skills and experience in the brain. Her body comprises many sources of somatic capital, which can help pass nutrients to the offspring. There may be material capital, financial resources, the quality of housing, and so on. And there can also be social capital, members of the social group who are going to help her provide maternal care or family care for the offspring. So maternal capital is what drives investment in the next generation, but of course there can also be competition amongst the offspring, even taking into account the fact that humans produce typically one offspring at a time. So there's a competition of maternal capital in terms of it being invested across successive offspring. Next slide, please. So we can think about trade-offs that are made throughout the period of development, and I'm going to come on to some of those in the next part of the talk. But even if we think of a trade-off that involves growth that is made in childhood or adolescence, all trade-offs later in the life course are made under the influence of those that occur earliest in the life course. And if we take the chain all the way backwards, eventually we find that the earliest trade-offs are made under the imprint of maternal capital. So this makes maternal capital really important in driving the life history adaptations of the offspring. Next slide. just to give you a couple of examples of how maternal capital is associated with patterns of linear growth in the next generation. So again, this is a study of a number of low and middle income country populations, and you can see that maternal height on the x-axis predicts the relative risk of stunting in the offspring and also the risk of mortality in the first 5 years. Shorter mothers end up having, on average, shorter offspring. Next slide. But we can see very similar patterns if we look at markers of social capital in the mother. Now, this combines data from 96 different countries, so each country here is a data point. And what we have on the x-axis is the gender equality index. A higher score means higher levels of gender inequality in that country. And here you can see that worse gender equality is associated with a higher prevalence of low birth weight and a higher prevalence of stunting amongst young children. So when women experience a worse condition in social life in their environment, then that too will have an impact on child growth. Next slide, please. So now we can join these two aspects of our thinking together. We can think about how offspring make life history adaptations, and we can think how they do that in response to the magnitude of maternal investment. So this is a very simple schematic diagram illustrating that. On the left-hand side, we have maternal investment during early critical windows, which would be pregnancy and lactation. And I've set the diagram to illustrate the consequences of low maternal investment. And you can see that that would predict a faster pace of life history in the offspring. If the offspring starts life with low maternal investment, it's likely to construct a poorer quality body. That means its life expectancy is likely to be shorter, and therefore it would need to reproduce earlier. So in association with that faster pace of life history, we would expect less energy being allocated to growth, less energy being allocated to metabolic health, and instead more energy being allocated for reproduction and potentially defense. Next slide, please. So we first tested this hypothesis in a small study of South Asian women living in the UK. And all of the predictions on the previous slide were supported. In this study, we used the women's birth weight as a marker of their nutritional investment when they were in utero. So in the top left-hand corner, you can see a positive correlation between birth weight and age at menarche. Daughters who received more nutritional investment in utero were going through their life more slowly, and that meant that they took longer to mature. On the top right-hand corner, you can see that the later age at menarche was associated with taller adult height. By extending the period for growth, it was possible for the women to become taller. Conversely, in the bottom right-hand corner, you can see that an earlier age at menarche was associated with higher levels of body fat. So now we can see that the age at menarche in this population articulates, if you like, a choice between becoming taller or becoming fatter. And finally, in the bottom right-hand corner, we can see that higher levels of body fat are associated with higher systolic blood pressure. Now, none of the women in this study had anything like a blood pressure approaching hypertension, but we can still see that higher levels of body fat are associated with a marker of poorer metabolic homeostasis. So exactly as predicted, the magnitude of maternal investment shaped the pace of life of the daughter, the relative investment in competing traits such as growing taller or fatter, and metabolic health. Next slide, please. So those results were very interesting, but they were also somewhat preliminary. And in particular, we didn't have any prospective data about those daughters in early life. We'd gained their birth weight data retrospectively. So to make further progress on this issue, I was able to analyze some data from the Pelotas 1993 birth cohort. Many of you may know that Pelotas is home to 4 different birth cohorts, which have a great international reputation. So they come from the south of Brazil. And I've been very fortunate to have been connected with the 1993 birth cohort for many years. So we were able to analyze data on 2,091 mother-daughter dyads, where we had prospective maternal data at delivery and data on the daughters in their early life, and then follow-up data on the daughters at 18 years of age. Now, we actually have data on the sons as well, and I've run the same analyses on those, but I haven't published those, so I'm just going to stick to discussing the daughters' data today. Next slide, please. To get a better idea of the impact of maternal capital, we made a composite score. And we did that by making 4 thresholds to define women, if they were below that threshold, as having low capital. And these thresholds were height of 150 centimeters, pre-pregnancy BMI of 21, maternal education of less than 6 years, and a family household income of below 3 minimum salaries. Now, a minimum salary is a conventional way of assessing household income in Brazil. In the year the study started, one minimum salary was $31 per month. So you can see that we're talking about family income below $90 per month. Next slide, please. Now, we then counted up the number of penalties for each woman. Was she short? Was she thin? Was she relatively uneducated? So you can see that conceptually, there's a very simple association. The lower the level of maternal capital, the higher the number of capital penalties. And obviously, the more mothers had capital, the fewer penalties they had. Next slide, please. Now, the first thing we looked at was whether, as expected, low levels of maternal investment steered the daughter towards early reproduction. So as you can see on the left here, consistent with that hypothesis, the higher the number of capital penalties in the mother, the higher the proportion of daughters who had reproduced by the age of 18 years. Now you might think, well, that would be mediated by an earlier age at menarche, but we didn't find that at all. So on the right, you can see that there was really no linear association between maternal capital and the age at menarche. And in fact, the mothers with the lowest capital had the daughters who had the latest menarche. And that effect may explain why on the graph on the left, the lowest capital mothers didn't actually have the daughters who had the highest proportion reproducing early. The pattern slightly went down again. So yes, maternal capital or low maternal capital predicts early reproduction in the daughter, but not mediated by early menarche. And that suggests a constraint on the energy supply of maturation, but not necessarily on the energy directed to reproduction itself. Next slide, please. Now, when we looked in more detail at which specific aspects of maternal capital predicted early reproduction in the daughter, we were a little surprised to find that it was pretty much all of them. So in this logistic regression analysis, you can see that young maternal age, short maternal height, low maternal education, low household income, being a higher parity mother, which means more competing offspring for resources, and smoking in pregnancy, which can be considered a marker of both risk-taking behavior, but also exposure to psychosocial stress. All of these traits predicted early reproduction by the daughter. And the only trait which didn't independently make that prediction was low maternal BMI. So very consistent evidence that low maternal capital predicts early reproduction in the daughter. Next slide, please. And we can immediately see that that is closely associated with patterns of linear growth. This slide shows the growth of the two groups of daughters categorized by whether the daughter had reproduced by 18 years or not. You can see that the daughters who reproduced early were already quite different at birth. They were shorter and they were lighter. During the first year of life, they became further behind in terms of their length growth, but they didn't lose any more weight. And then between 1 year and 18 years, they caught up in weight, but not in height, so that in adulthood, they were substantially shorter, but they were the same relative weight. Next slide, please. Beyond that reduced investment in height, they also invested more in their central fat. So this slide shows a plot of their subscapular skin fold relative to their triceps skin fold. And you can see for any given level of triceps skin fold, the early reproducing daughters had a higher subscapular skin fold. Now that's not only highly significant statistically, but the magnitude of the effect is biologically important as well at 2 millimeters. So the early reproducing daughters were investing more energy in central fat, a marker of defense. Next slide, please. If we look in more detail at patterns of growth, then you can see that the lower the maternal capital, in other words, the higher the number of penalties, then the smaller the daughter was at birth, the shorter was her adult height, the lower was her adult fat-free mass, and also the lower was her total fat mass. So you can really see composite effects and dose response effects of lower capital on poorer growth in the daughter. Next slide, please. But once again, if we just look at maternal investment proxied by maternal capital penalties, we see a more central distribution of body fat. So here again, these are the subscapular skin fold residuals expressed relative to the triceps skin fold. So a low capital mother has a daughter with a more central fat distribution. And here we haven't stratified by whether the daughter reproduced early or not. Next slide, please. So now we can connect the life history strategies of the two generations. First of all, we've been looking at the mother, and we've been asking, based on her capital, how much energy she can invest during reproduction. And then we've been looking at the life history trade-offs in the daughter, and considering that a low level of investment by the mother seems to result in more energy being allocated to reproduction, given by producing a child by 18 years, and more energy being invested in defense, shown by higher levels of central body fat, and then less energy in growth and maintenance, shown by less fat-free mass and less height. Next slide, please. If we want to look at the interaction, then the finding is that the exposure to low maternal capital, which we saw promoted reproduction, interacts with that outcome. In other words, the worst daughter outcomes in terms of health occurred in daughters whose mothers had had low capital and the daughters who had gone on to reproduce early. So there was like an additive effect. Next slide, please. Okay, so that study helped us understand these trade-offs that emerge early in life in response to low maternal capital. But what about later during development? For example, is it still possible to see trade-offs between linear growth and other life history functions during adolescence? So to investigate this, we've been analyzing data from a large cluster randomized trial in lowlands Nepal. Our associations that we've been reporting observational, but they take into account the randomized nature of the data. So in this population, which is a Maithili-speaking population from the Terai, it's conventional for women to get married at relatively young age. The median in this population was 15 years of age. And the women move from the natal to the marital household. They're relatively young, and when they arrive in the marital household, they're essentially at the low end of what can be quite a steep family hierarchy. So life can be quite tough for them. They don't have much autonomy. Next slide, please. So we predicted that both early marriage and early childbearing might potentially have an impact on growth during the final period of development. But there could be different mechanisms for these two different hypotheses. Early marriage might have effects on dietary intake, and it might also expose the women to psychosocial stress. Now we know that the stress response consumes energy, and that might reduce the energy available for growth. When it comes to early childbearing, producing an offspring introduces competition in the mother for nutrients. And so again, if the mother had not yet completed her own linear growth, getting pregnant might reduce the magnitude of growth that she completed before reaching her final height. So we wanted to test both of these hypotheses. Next slide. And we found that both hypotheses were supported. The first model looked only at early marriage. And as you can see, the younger the woman was married, the lower was her final height. The second model looked just at early pregnancy. And again, you can see that becoming pregnant before 16 years of age was associated with 0.87 centimeters shorter adult height and a smaller magnitude of effect for reproducing at 16 to 17 years. When we put them both in the same statistical model, we could still see effects of both of these exposures. They were both attenuated. Nevertheless, both early marriage and early reproduction appear independently to predict shorter height of individual women. Now, there's always the possibility, you could say, that perhaps it's shorter women who are prone to getting married earlier. So we did our best to control for that, and we did that by adjusting for characteristics of the marital household, such as the wealth index and the education of the husband. But when we made those adjustments, we found that our associations of early marriage and early reproduction of the mother with height didn't really change. So we don't think that this is a selection effect. We think that the associations are a genuine response to the two exposures, although we still don't know in detail the mechanism. Next slide, please. Okay, so we've seen how stresses during early life or during adolescence can impact linear growth. And we know that therefore height can be compromised. But we also know that height can increase over time in populations, suggesting living conditions have improved. By far the best known example of this is what took place in the Dutch population over the last 160 or 200 years. You can see here that between 1840 and 1980, there was approximately a 20 centimeter increase in male height. And in women, there was a fairly similar increase as well. So clearly, populations can become taller by reducing stresses. Next slide, please. If we look at secular trends in height globally, however, we get a very mixed picture. These are some fantastic data produced by the NCD Risk Factor Collaboration, and they've modeled secular trends in height globally. And here you can see the data for males. And you can see while there have been quite significant and substantial secular upward trends in height in Latin America, Australia, North Africa, and Europe, there have been very, very small magnitude of effect trends in sub-Saharan Africa and India and parts of Southeast Asia. Next slide, please. And you can see a relatively similar effect in women. And in fact, some studies have even documented a negative secular trend in recent decades in India following the introduction of structural adjustment policies. Next slide, please. On the other hand, while height may not have changed very much, we know there are other secular trends that may be going at a faster speed. This is not a very easy slide to see because it's got so many plots on it, but these are data for BMI secular trends in males according to different global regions. The dotted line at the top is for children and for adults, and the lower line is for children. And you can see that in every global region, there has tended to be a secular increase in BMI between 1980 and around 2015. Next paragraph, next slide, please. And you can see very similar secular trends in females. So this is really something that's happening globally, and there's a contrast to those height trends. Next slide, please. Another trend that we can see is in the age at menarche. Now, there are only a few studies through which we can assess this, but here are the available data that I was able to find in the literature. And you can see that all of the countries, with one exception, rural Cameroon, had reported a decline over time in the age of girls' menarche. And the magnitude of the effect per decade ranged from close to 0 to 0.8 years per decade. So girls are maturing earlier, even if they're not necessarily getting taller. Next slide, please. So if we add all of this together, we could say that changes in time in growth in sub-Saharan Africa and parts of Asia are relatively modest. And yet it seems as if the relative investment of energy in defense and the potential of reproduction is greater. So once again, we're starting to get insights from life history theory about how human phenotype is changing in response to this composite nutrition transition. Next slide. So then we have to ask the question, well, if we improve and increase nutritional supply, will we actually improve growth and health, or will we simply contribute to this greater investment in defense and reproduction? In other words, will we simply make people fatter? Next slide. So that connects us with what's now presented as the double burden of malnutrition. And this refers to the fact that markers of undernutrition and overweight can coexist. This was first reported at the level of individual countries, then it was reported within communities, and finally in households, as for example, where an overweight mother has a child who is either underweight or stunted. But as the speed of nutrition transition has accelerated, next slide please, what we're actually seeing is that it's possible for that undernourished or stunted child to grow up and become an overweight adult, for example, an overweight mother, who will then produce children from a very different metabolic phenotype. Next slide, please. So we've long known that there are intergenerational cycles of malnutrition. We know that undernourished mothers are prone to give birth to children who are at risk of undernutrition for the composite environmental effects. And we have the same scenario for maternal overweight. Overweight mothers are likely to have children who also have an increased risk of themselves becoming overweight. Next slide, please. But what rapid nutrition transition is doing is shifting individuals between these two phenotypic cycles within their life course. And that life course shift is strongly associated with a range of diseases. Next slide, please. So one very clear example is given by diabetes. These are data from the New Delhi cohort. And at the front of the graph, we have body mass index at 2 years of age. Up the right-hand side of the graph, we have adult BMI in the same individuals. And we're looking at the odds ratio of developing diabetes or glucose intolerance in adulthood. And it's very easy to see that the highest risk of diabetes occurs in those who are thin at 2 years and overweight in adulthood. And this pattern of disease is easily seen for many other non-communicable diseases such as hypertension, stroke, cardiovascular disease, and so on. Next slide, please. Now, this slide looks very complicated. It's what we call the biology of the double burden of malnutrition. But really, I just want you to focus on one or two aspects of it. The gray boxes down the center of the diagram incorporate a number of different forms of ill health: inflammation, gut dysbiosis, feto-pelvic disproportion, in other words, obstructed labor, and cardiometabolic diseases. And all you really need to see is that there are arrows coming into those boxes from each side of the diagram. In other words, each of these disease states picks up the influence of both undernutrition in early life and also overweight in later life. And so this helps us understand why the double burden of malnutrition is really driving the global epidemic of non-communicable disease and actually many other forms of ill health as well. Next slide, please. So if we were to treat malnutrition, we want to promote growth and the acquisition, the accretion of healthy lean tissue, muscle mass, organ mass. Those are very important health outcomes to us, but we don't want to cause excess fat deposition. In particular, we don't want to cause excess body fatness in short children. We also need to ask ourselves, at what point does gaining fat become bad? Is there a lower level at which actually gaining fat is good? Next slide, please. So I want to end by presenting data from 2 studies which have been interventions providing treatment for different aspects of malnutrition. And just to show you what we've seen in terms of growth and body composition, because in these trials, alongside overall recovery, body composition was the primary outcome. So the first study comes from Burkina Faso, and it involved 1,609 children who had moderate acute malnutrition. They were aged 6 months to 2 years at baseline. And over 12 weeks, they were given one of 12 nutritional supplementation products. So in this trial, there was no control group because it wasn't ethical not to give something to any child. The products can be differentiated in the following way. Overall, the products were either based on a corn-soy blend or a lipid-based nutrient supplement. Within each of those groups, they also had either dehulled soy or isolate soy. And then within each of those groups, the supplements could vary according to them having 0 milk protein content or 20 or 50% protein from milk. So we gave the children in randomized form one of these supplements, and then we looked at the change in body composition over the 12 weeks. Next slide, please. So overall, the children gained 0.9 kilograms of weight. And it was very pleasing to see that 93% of this weight gain, the vast majority, was on average lean tissue, and only 7% of that weight gain was fat. So the simple answer is that if you give these moderately undernourished children more food, they gain lean tissue, not fat. The intervention was too short to look at growth as a primary outcome. There were some subtle differences between the different types of product, but overall, all of these products were beneficial for gaining lean tissue. Next slide, please. When we looked at possible differences in this trial according to whether the children had been short or not at baseline, we found that actually the short children on average gained no fat. The entirety of their weight gain comprised healthy lean tissue. And then in the not short children, still the vast majority, almost 92% of the weight gain was still lean tissue. So there's no indication that short children are unable to benefit from nutritional supplementation. Next slide, please. Then we did a similar trial for severe acute malnutrition, also in Burkina Faso. These children are much more undernourished, but they were still being treated in outpatient care. There were 452 children enrolled in the start of the study, and 259 went on to complete the study and had end-line measurements. And we also had in this study 97 data points from healthy control children who were not affected by malnutrition. In this trial, the overall weight gain of the malnourished children was 1.2 kilograms. But there was a contrast here compared to the previous study, in that now just under half of the weight gain was lean tissue and just over half was fat tissue. So you could say, well, this time, have we not just made these children fat? Maybe this isn't such a healthy pattern of weight gain. Next slide. But when we compare the children against the healthy controls, we see something very interesting. All of these data express the deficit of the malnourished children relative to the control children. The fat-free mass and fat mass values on the left are unadjusted for height, and the fat-free mass index and fat mass index values on the right are adjusted for height. What you can see is that during treatment, the deficit in fat-free mass reduced, and at recovery, there was no deficit left in fat-free mass index. In other words, proportional to their height, these children had caught up in their lean tissue. If we look at the fat mass data, then there was a reduction, but it was only partial. So by no means have these children become fat. They have just lost some of their deficit in fat tissue. Now, I've been talking throughout this presentation about the fact that sensual fat in particular has benefits for immune function. So what these children are demonstrating is the ability to make good their deficit in lean tissue, but also to capture some of the benefits of increasing their fat stores to improve their resistance against infections. So there's no indication in either of these short-term studies of the treatment of malnutrition that the children have done anything other than invest the energy in ways that are good for both short-term survival and longer-term healthy growth, and hence likely health. Next slide, please. So in summary, growth retardation can be considered a trade-off between growth and other biological functions. And we can understand that by thinking which other functions are affected and how might they represent adaptations to environmental conditions. What we're seeing is that often it's the other functions, not growth, that are preserved in adverse conditions. And if we want interventions to be successful, then we not only need to improve nutrition, but ideally also to reduce these other stresses. We've seen that treatment for malnutrition in the short term can build lean tissue, and over the long term, that is likely to also support linear growth. And we know from longer term follow-up of some of these trials that I didn't present, that undernourished children, severely undernourished children, do catch up in height over successive years. We've also seen that treatment doesn't have to promote excessive fatness, but we can also modify that a little bit by the composition of the supplement that we provide. And finally, because some of these linear growth deficits are already evident by the time of birth, we should think in the future about interventions that could target pregnancy. In other words, to change life history trade-offs in utero and see if the fetus can be healthier by the time it's born. Thank you very much for listening.
Thank you, Jonathan. I'm going to stop the share. Thank you. Sorry, I'm just trying to close your presentation on my screen so that I can see what's going on the questions front. That was really interesting. We're just waiting for some questions to come in, and I had something that I would like to ask, going back a bit to the life history question. I thought your initial studies you talked about were really interesting, how that there was really this correlation as you go back into the life events. how birth weight then influence the next thing, and so on. And it made me think really about how coherent life history strategies are, so to speak, in humans. And of course, there's a lot of other research, kind of stuff that we've all seen before, you know, looking at age of menarche and pregnancies. And then I guess ultimately the goal is to have more, or the expected goal is to have more children. And I'm just sort of interested on your thoughts of what you think about how coherent these kind of strategies are for human groups.
I don't think humans are trying to have coherent life history strategies beyond a certain point. And I think I'm fairly well known for being quite resistant to the idea of the predictive adaptive response hypothesis, that you somehow know what your life history strategy would be because of some hypothetical future environment. I think we've ample evidence that poor growth in early life predicts a shorter lifespan. And on that basis, we can already see some trade-offs emerging. But every time we pass through a window of time, we have to make new trade-offs, and those are unpredictable. And therefore, we shouldn't really expect wholly coherent trade-offs, because if that was the case, we would give up on every public health intervention once a child had suffered an adverse event. If we think that we know where things are going, well, we would never change anything. The principle of public health and medicine is you can always improve health. So I don't see any reason why life history trajectories need to be locked in, and that once you know where you're going, you just go there. I think rather that at any given point in time, the body is likely to make trade-offs, and those trade-offs will be made under the influence of the previous trade-offs, and the body can change track. And if conditions get better, which is what we're always hoping for, we will change those trade-offs. So I think we should think of trade-offs as being cumulative. There's always something that can change, and quite often there's something that can no longer change. For example, we don't normally change in our growth in adult height. So that opportunity to grow taller, we've lost that one. Or we've got something else. We can gain energy stores, or we can behave differently. So I think whilst there has to be a degree of coherence, and that something has to knit everything together in the broadest sense, you are the person making the trade-offs. I think nothing really constrains trade-offs in the sense that they're always going to go in the same direction. And I think, as I say, that's the kind of principle of public health. You can always do something.
That's interesting, and it probably explains quite a lot of the sort of incongruous findings, you know, and just on individuals, people's trajectories and their changing circumstances and their, you know, local environment. And this kind of follows on from that quite well. Somebody's asking, how do you think interventions could target pregnancy? So the maternal phenotype, as it were.
Pregnancy is undoubtedly difficult, and we do know that when a mother herself is undernourished in early life, and she may have a phenotype that still reflects that, making the baby bigger in utero isn't necessarily a cost-free intervention. However, there's other reasons to suggest that we can improve fetal growth, and I think we really shouldn't give up on intervening to improve fetal growth. We can do things before conception, we can do things during pregnancy. One interesting thing for public health interventions is that by convention, we start working with pregnant women when they are already pregnant. It's when they come and they say, oh, I'm pregnant. And so you've already missed the earliest window of opportunity in the early stages. And this may well be one reason why pregnancy interventions have not actually been very successful, because they've started too late. And I think that's becoming recognized in the field. I don't know if you've heard about the WHO Healthy study. This is introducing interventions prior to pregnancy, and is planning to follow the children up to 5 years of age. And the answer that they're seeking is, if you really get going early, what can we do? If we bring together every possible known intervention that could improve fetal development. So I think there's a lot we could do, but I don't think we have a very good evidence base so far.
Yeah, because it does, just thinking about it like that, you sort of go backwards and backwards. If we we help the children, but it's better if they're helped in utero, but then it's better to help the mothers before they're pregnant. Then it's better to help the, the adolescent girls. And then, I guess, yeah, it's hard to think about where the best targets are.
Well, I think a very pragmatic response, first of all, is that you can always do something. But the thing that always stands out for me is mothers often have more than one children. If we help mothers, you may pass benefits on both to the mother and several children. And this seems such a logical starting point that I think you can't go far wrong if you try and help mothers.
Absolutely. Okay, somebody's saying, thanks for a fantastic talk. I was interested in the Pilotus data from Brazil. It seemed like many factors, low maternal height, low education, younger age at birth, etc., were all independently associated with lower age of childbearing in daughters. Could you comment on to what extent did these may be a function of the social group a mother and daughter belong to versus independent of social factors? That makes sense.
So we asked the same question. Are we just seeing the propagation of family tendencies over time? We didn't have the mother's first reproductive age, so we couldn't control for that. So we kind of lost the most obvious thing that we would have liked to control for. However, wherever we did have the same trait in the mother and the daughter, for example, years of education. So we could say, because we ran many more analyses than I presented today. So we looked at education, all sorts of things, smoking. And the answer is that whatever the association between the mother and the daughter, early reproduction had something else to say for almost everything. So what you can say is, taking into account that daughters may replicate traits that their mothers showed, there's an independent association with early reproduction. So I think this is not just the transmission of living conditions. Obviously, the low capital mothers are living in adverse living conditions, and their daughters are experiencing exactly the same conditions, or they're likely to. Obviously, there's some social mobility as well. You could say, is this just each generation experiencing the same stresses? And the answer is yes, to some extent that would be true. But at an individual level, not all of those daughters from the mothers with low capital did have a baby by 18 years. So it's not like it's a fixed outcome. So to the extent that we could make those adjustments, we still saw an independent indication that the daughter's life history trajectory was leading to those same outcomes. Well, that's a very good question.
When you say a mother is undernourished in early life, is there a cutoff age? For the mother, I mean, for example, if she's undernourished for 2 years and then fed plenty from 2 onwards.
So as we saw on the linear growth filtering chart, linear growth essentially becomes relatively resistant to nutrition around 2 years of age. Now, the sad thing is that you can slow growth by undernutrition, but you can't really put back height that is not manifested by that time by giving more food. So what tends to happen is if you make a nutritional intervention in childhood, especially if it's not particularly healthy, is that's when BMI goes up and height can't change. So that's why we pay so much attention to the first 1,000 days of life. This is the most plastic period, and linear growth, you can always say, why does it matter growing a little bit taller? What is that extra centimeter of height doing? Well, the answer is that extra centimeter of height is making the pelvis bigger. It's making the organs bigger. There are many benefits that come from growing in early life that you will simply not get later in life. So we really do care a lot about linear growth in this first 1,000 days. And after that, we shift to targeting other traits. As I say, there's always something we can do to improve children's health, but we probably can't make them catch up in height substantially. There is an argument about whether adolescence is a window for catch up in height. Possibly it is, although I've not seen intervention data. I'm not seeing whether a trial was actually successful. There's observational data showing that in the Gambia, for example, showing that shorter height in early adolescence faded by later adolescence. But we don't know if an intervention would actually have the same effect. And we also don't know if you make someone grow in adolescence, if it will give you all the traits that you can get by growing in earlier life? Will it reduce diabetes risk? And so on. Will it have educational payoffs if you've already finished most of schooling? So even if adolescence is a critical window for linear growth, for example, in the Nepal study, I would say that what you really take away from the fact those mothers were shorter if they married early and they reproduced early, it may not be that the shorter height is the most important thing. It's a marker of their stress. They weren't investing in their linear growth. They probably weren't investing in cellular health. They probably weren't investing in their physical and mental health. It's just a marker that life is tough.
That makes sense. And that explains a lot to me in terms of a lot of the studies I've read about height. The differences are so tiny. You just think initially, like, well, what difference can a couple of millimeters really make? Height, it's your hair.
This goes back to the issue of stunting. People say, oh, look, the children are short, but they're fine, they're okay. Well, why are they a higher risk of mortality? And it really is a substantial increased mortality risk. So they are not just short children. They are short children who've come from very adverse conditions. And as I say, they've often been severely undernourished and then recovered from that, but it's left them short. And so we really need to take stunting seriously. And we know that stunting in childhood is associated with poorer metabolic health, higher diabetes risk in adulthood.
Thank you. There's a question here. Can you talk at all about menopause? We've spoken a little about age at menarche and how it changes, but can you talk to age at menopause, and do you have any hypotheses?
So I know very little at menopause, so that's the main thing I should say about it. I did look at secular trends in life history traits, again with my colleague Jay Stock, and we published a paper in Trends in Endocrinology and Metabolism, I think in 2011 on that. So that might be worth having a look at. We were interested in what can change across generations or across decades in life history traits. And while menarche shows a tendency to go down, menopause shows a tendency to go up. So the overall effect is a lengthening of the female reproductive career. And yet we're not seeing increases in fertility. So we're seeing a potential for fertility that then through behavioral means are not being converted into actual offspring. But more than that, that's about my only insight into menopause. I think it's really understudied from an evolutionary perspective beyond the grandmother hypothesis, and would be a very interesting topic.
Yeah, that's exactly what that makes me think of, because if menopause is actually being pushed later, maybe that's something to do with age at first birth of daughters being pushed later as well in these economies with low fertility. Maybe the grandmothering then, I don't know, I'm thinking out loud, but that this.
I also have no idea what's happening within a population. For example, are poorer groups experiencing menopause earlier or later, and whether it's changing over time to the same extent in all socioeconomic strata. So many unanswered questions there. And you can imagine that getting data on menopause supported by comprehensive early life data, this may not be super easy, but would be a great topic to research.
Yes. Yeah, we definitely need more data. I think that's all the questions we have. That was such an interesting talk. Thanks for being our final 2020 speaker. And despite initial small hurdles, everything went smoothly. So yeah, and just to say to everybody out there, thanks very much. We'll be back again next year. So tune in again, stick on with the following the channel, and we'll get updated. And hopefully this time next year, everything will be a little bit more back to normal. Thanks.